welcome back to another episode of Alate Health Presents. I'm Dr. Andrew Doe, and again with me is Dr. Michelle Maneevese. We're here to talk to you today about interventional radiology. Dr. Maneevese?
One of my favorite topics.
Yes, so what I wanted to do today was talk about the questions we are most frequently asked, whether it be with our fellow physicians or whether it be from patients or whether it just be from the public and concerns about interventional radiology, knowing what it is, what we can do, and why we can do what we can do. So tell us, Dr. Maneevese, what was your impression of interventional radiology before you went into it?
It was non-existent because our specialty is relatively new, so not a lot of people know about it. But once I got into radiology residency and got to see all the things that IR can do, it just seems like this Barney's bag of anything possible. And all these things were possible through a tiny pinhole. Everything was minimally invasive, and you can make a big difference and a big impact and no one would know that you were there.
Excellent. Yes, interventional radiology is often called modern medicine, or one of the aspects of modern medicine, and we're able to replace large surgeries that were not only large surgeries, they were very stressful for patients, very difficult for the physicians to perform, and now we can do that kind of, as you said, through a pinhole. So can you tell us a little bit more about interventional radiology and why it's so safe even in an outpatient setting?
Sure. So if we think about interventional radiology, it's making big things small. So big changes with as small of an impact while we're doing the procedure. So a lot of our procedures start with getting access into the blood vessels. The blood vessels are the highway that connects everything in the body. And once you're in that blood vessel, you can treat any part of the body. One of the things that we do here at Alate is fibroids. So a big surgery, something big that the patient would have to go through would be a hysterectomy or a myomectomy. So instead of having something that is more invasive with interventional radiology through just a pinhole, we can treat these fibroids. And what we do is we gain access into the highway, we find the blood vessel that's feeding the fibroids, inject microscopic beads, and then stop the blood supply to the fibroids, and the fibroids shrink and go away. So making a big difference in a little way.
Yes, and for many of our viewers who have had hysterectomies or myomectomies, or even our patients who have had C-sections for babies, those are big surgeries, big incision in the belly, and you've got to work in that area. There's a lot of blood vessels and other parts to other systems that you have to worry about damaging when you're doing these large open surgeries. Whereas when we go into the highway, which is a great term, and we find the road to the fibroids, we're in such a confined space that we really can't affect a lot of other systems without, doing something, that would be crazy. I mean, the standard procedure for what we're doing, we really protect all these other systems. Now, what is it about interventional radiology that allows us to do these things? What tools do we have that, the surgeon doesn't have?
So what I like to say is we're the eyes of medicine. So we have what I call the truth machine, and these are different imaging modalities that we use to see inside the body in a non-invasive way. So we don't have to cut anything open to peek inside and see what's going on. We can see it with ultrasound. We can see it with CT. We can see things with, and what we use the most here at Alate, fluoroscopy. So they're x-rays that go down. A lot of the patients say, well, you're in the highway, and you used ultrasound to go to the highway, but how do you know where you're going? And so that's when we use our big x-ray machine, our fluoroscopy machine, to see where we're going and to guide our catheters and our wires.
Excellent. And what about a patient who may come to you and say, I like the idea of doing this, but I'm worried about the radiation. What kind of radiation, what kind of exposure do patients get when they're going through an interventional procedure?
So it really depends on what procedure you're doing. If it's a larger procedure like a uterine fibroembolization or a prostate artery embolization, those can last a little longer. The good thing about Alate Health is Dr. Doe and I are so experienced in these procedures that our procedure time is really low. We spend a lot of time planning the procedures. We get a peek at your blood vessels when you get imaging before, like your MRI or a CT. So there's really not that much time that you're actually under the X-ray machine. A lot of times you can compare it to a flight. So a flight from here to New York and back, generally, that can be what you compare it to. In addition, we do a lot of things to save the patients from unneeded radiation. So Dr. Doe and I know all about radiation safety and minimizing the dose to both the patient and us and our staff.
Yes, and this is an excellent point. There are many different medical specialties that use radiation, use the fluoroscopy machine like we do. Some of them do similar procedures to what we do. But interventional radiologists are the only specialty that are actually board certified in physics, and not only physics, but radiation safety physics. And that's a key point to kind of minimizing any complications of a radiation exposure. Now, you said we get into the vessel with ultrasound. Can you show us a little bit? I have some show and tell devices here.
We have some toys. Okay, so I will say, since we're on the topic of frequently asked questions, a lot of patients get nervous when we say we enter the highway through the groin because they've had other procedures by other specialties and they've had complications with that. There are complications that you can get from having an IV in the groin, like a hematoma, a big bruise. And how we minimize this as interventional radiologists is we're using an ultrasound the entire time. So real time, we get to see our needle as it approaches the vessel, as it makes contact with the vessel wall, and the minute it's in the center of the vessel, that's when we stop. So there's no guesswork about it. We really get to see real time, and it's safe and it's easy for us to do each and every time. So what we start off with is a micro puncture needle. So this is a teeny tiny needle, and all of the names of our tools are micro, mini, like very small things, just to really emphasize how minimally invasive we are. So we start off getting access into the highway with our ultrasound machine with this needle, this teeny tiny needle. And for our procedures, our patients are sleeping. So I know we've had IVs placed before in the hospital and you were not sleeping, but we really, really want you to be comfortable here at Alate. So after this needle's in the vessel, a tiny micro wire, see all the names are very tiny, fits through the needle. And now we have access into the vessel through this teeny tiny hole. And when we say it's a pinhole, it really is a pinhole. And all of our procedures are done after we exchange out and place the IV in. So this is like about the width of a spaghetti, would you say? So all of the procedures done through this IV, all of our catheters, all of our wires fit through this tiny IV. So if you were to be awake for the procedure, you really would just feel the IV going in and the rest of the procedures in your blood vessels, and you don't feel anything in your blood vessels, but everything is done through here. So as minimally invasive as it could possibly get.
So we have all these different tools that we can use, when it comes to patient anatomy, and everyone's different. Humans are very unique, and even, we used to say in medical school that they didn't follow the textbook. So everything wasn't where it was supposed to be. Do we have different things that we can do to overcome these variations?
So I think overcoming variations, the first step in that is seeing enough of these variations and being familiar enough with these variations to know where you are, what you're looking for. Helping us get into the different anatomical variants. If a patient has specifically curly Q vessels and they're hard to get into, we've got different types of wires and catheters that will work depending on what curve we're looking at. So, for example, this is one of our catheters. Again, teeny tiny, fits through the IV. So all of this is done, again, through the exact same pinhole. And we've got different curves to it. And on top of the curve of the catheter, when we place our wire through, the wires also come with different curves as well. And some of these are shapeable, so if you know what you're up against or you know what kind of curve you need, you can actually change the curves to these instruments.
So all of this, not only do we have different tools with different shapes and all those different things, but we can also manipulate the tools we have to change them. So even within a difficult procedure, having enough experience, having enough tools, you can safely navigate just about anybody's anatomy. And at Alate Health, we really pride ourselves not only on being able to do difficult cases, but also to do them in a timely fashion and minimize patients' risk to the radiation exposure. Now, why is it that interventional radiology can be safely done in an outpatient setting?
So the only thing that you'd have to worry about when you're done with the procedure is your access site. And so we use different devices to plug up the artery when we're done. The one we use most frequently, AngioSeal. For procedures that we don't use heparin, the patient just has to lay flat for 20 minutes, and after that they can go home. So there's really no need to keep them in the hospital overnight. There's no need to monitor them. All of this can be done in the outpatient setting.
Excellent. So we're touching more on what interventional radiology is, what some of the common questions we encounter about the specialty, and after this short break, we'll come back and we'll finish up and answer some more questions that we commonly see. Stay tuned.
Light up your new year with a top-rated luxury SUV from Ron Carter Cadillac. Drive the new 2021 XT4 Luxury Collection for $319 a month, the new 2021 XT5 Luxury Collection for $399 a month, or the new 2021 XT6 Luxury Collection for $459 a month, all for 39 months lease with just $1 down. Gulf Freeway, just 2 minutes south of the Beltway.
Shop smarter when you shop Ron Carter. RonCarterCadillac.com.
When it comes to protecting yourself and your partners, all the information out there can be overwhelming. Visit our website. We are a free and confidential service striving to help you stay informed and stay notified. We are committed to a healthy Houston.
Amazing things for you.
Welcome back to another episode of Alate Health Presents. So before our break, I was elaborating on why interventional radiology is perfect for the outpatient setting. Dr. Doe, do you have any more points to add to that?
Absolutely. So one of the big things that you worry about anytime you're having a medical procedure is what are you going to be exposed to going in for that procedure? And we used to always say in medicine, the last place you want to be if you're sick is the hospital. And that's because, especially in the times we're in now with COVID-19 and all those things, you don't want to go into the hospital for fixing the blood vessels in your legs and get exposed to COVID-19. So at Alate Health, patients don't intermix. We don't have multiple departments throughout the office. It's basically you're there, you're treated, and you're finished, and then you go. Everybody's kind of separated within the office, and you're not exposed to a lot of other ailments, as it were. So I think that really sets you up for a safe setting. We also have anesthesia within the office. You're never more than 6 feet away from one of the staff members. So it's very self-contained, and it's very much an efficient way to address patient concerns and to also keep patients safe from other diseases they would normally be exposed to in the hospital setting or even in the outpatient setting of the hospital.
So this safe and efficient manner, does it come with an extra price tag?
Actually, doing it in our setting versus a surgery center or the hospital is much cheaper for the healthcare system. Typically, when we look at Medicare rates for our patients, it's usually 1/4 to 1/20th of what they would have to pay
Wow.
if it's done in the hospital.
Wow.
And, when we look at hospitals, hospitals are big. They're great big structures with lots and lots of employees and lots of waste, and unfortunately, they're not efficient. You have patients that linger in the hospital and come back and go and come back. So in the setting that we're in, we can be much more efficient. We can keep the size of the office down, the number of staff, and all those things, and we can really just focus on a few patients. And even though we're not getting the reimbursement of a big hospital, it's still enough that we can do it, and we can do it in a safe setting. We can provide everything that a hospital can provide without the added risk.
Again, making big things small, efficient, and safe. Going back to what we were talking about earlier with, what interventional radiology can replace in terms of big surgeries, what else can we do besides the fibroids that would also replace big surgeries?
Yes, so the fibroids, taking advantage of the blood supply, will kill the fibroids without taking out the uterus, the hysterectomy. With the prostates, we can go in there, we can plug up the blood supply to the prostate, and we can keep you from getting the TURP, which is, a drill bit that goes up the patient and kind of cuts out that tissue. You can avoid removing the entire prostate, which is, a very difficult, very long surgery with lots of complications. And going through such tiny means as this, we can effectively treat the patient's big prostate and save them from those complications, and also save them from any large scars or other issues that they may encounter. Now, another thing that we do a lot of at Alate Health is we fix the blood flow going from the heart to the feet. And the way we do that is by opening up blockages, whether it be a balloon or cutting out plaques. And those types of procedures have replaced, or can replace in most settings, what we would call a bypass. So if we're driving on I-10 and there's a big accident, which never happens, and we can't get around the big accident, what do? We go off onto the service road, or we cut through the local roads. We find a detour around it. And in the past, before we had interventional radiology, before we had all this great equipment and these great tools, we would basically connect a tube to one end of the healthy blood vessel, and then bring that all the way around until we were beyond the area where it was plugged up, and we'd sew it into another part of healthy blood vessel, and that would make a bypass around that blockage. And now at Alate Health, we can go right through the blockage, and not only can we get through it, but we can kind of take it out after that, and we can open up the blockage from inside. And the reason that these are such great procedures is you can repeat them over and over. And if you talk to a vascular surgeon or a cardiovascular surgeon, they can only do so many bypasses. You only have so many spots in the leg. Patients that tend to shut down a bypass are probably going to do it in a new one. It's not magic. So really the number of patients that are getting these bypasses now, these big surgeries that you have to be in the hospital for, in the operating room, you're going to stay overnight, the number of those procedures is going way down, and they're really reserved now for select cases. So, and then the end game of all of that kind of treatment is to prevent patients from losing limbs. And, when I came to Houston, I looked at a very large study, 21,000 patients for Medicare that had diabetes and that got an amputation. And Houston was unfortunately one of the areas that was kind of lagging behind in this type of treatment. So it was another factor in kind of pushing me to select Houston as a place to start Alate Health.
And we are so glad that you did. Hey, so let's, whenever you to start a prostate procedure, you start a peripheral arterial disease procedure, do you use these same things as for the UFI?
Yes, absolutely, Dr. Maneevese. Not only is everything we are doing these procedures with very small, every day it seems like the tools that we use, there's a newer version coming out that's even smaller, and it really decreases the trauma to the patient's highway, the blood vessel, And what I tell most of my patients is after you come in for a fibroid embolization or prostate artery embolization, or even a case fixing the blockages in your legs, you're probably going to have to look to find that incision. Typically, it's smaller than 1/8 of an inch. All of these things can go through that area. And in reality, the amount of damage we do, we're not cutting the artery. We're actually kind of just pushing it aside.
Right.
So when we're done, everything comes back together and it's easily, safely closed up.
Right.
And that allows the patient to get up and get back to normal quicker. Now, we talked about going from different areas, different specialties, doing different things. Can you talk to us a little bit about the newest fad? I know we've talked about it before, but going through the wrist for these procedures.
So going through the wrist is possible, right? Because it is just another entryway into the highway. Some interventional radiologists prefer that way, and it really is a personal preference. For what we do here at Alate Health, the risks associated with wrist access they kind of outweigh what we could do through the groin. I will say that the angle that if you were to come in through the wrist does make the procedure technically more simple, but Dr. Doe and I have spent a lot of time in our training, in our experience, to make sure that our procedure time doesn't suffer just because we've gone through the groin. So, we really dedicated our time to developing our microcatheter skills, to developing our skills to get in where we need to on that highway without sacrificing a limb or a hand in this case.
Yes, exactly. And typically, especially with fibroid patients, these are young, healthy women who are still having cycles, so they still have estrogen, which is a very protective hormone for your blood vessels. So they tend to have very nice, healthy arteries, so it doesn't matter, wrist versus groin. I think you're just adding risk by not using that access. So tell us in closing here, where can patients find us and what you have to say.
What do I have to say? So keeping big things small. Today our theme was frequently asked questions. If there is a question that you have and you're thinking of that you thought of while we were having this segment today, do not hesitate to give us a call. I would love to meet you. Dr. Doe would love to meet you, answer any and all questions that you have about minimally invasive procedures and how they can help your life. Dr. Doe, give them some information on how to find us.
Yes, you can always, if you have a specific question, you can use info@alatehealth.com. You can go to our website, www.alatehealth.com. And we have our 2 locations, which are both served by the same number, 713-955-1707. And again, those locations are 1213 Herman Drive in the Museum District of Houston and 12825 Gulf Freeway down near that Pearland part of Houston. And we'd like to thank you for joining us for another episode of Alate Health Presents. Until next time, for myself and Dr. Maneevese, thank you.